My test.
So it's 9:30. I think we should start our session.
Please start.
Okay. So very good morning, everyone. I am Professor Dr. Ashita Budebroy, and I, as moderator and chair for this session, and I, on behalf of Asia Pacific Advanced Network Medical Working Group, I welcome you all to this session for today. And today's session is on recent trends in pathology, from teaching methods to diagnostic tools. And today, the first session is by Professor Dr. Anup Kumar Bole. He is the professor in pathology at Bardhaman Medical College, West Bengal, India. He has been recently working on molecular methods in pathology and molecular pathology. And his topic is on the role of a molecular pathologist in this era of molecular medicine. So, sir, over to you for your presentation.
Thank you, Dr. Asita, for inviting me to deliver a speech on this topic in this 58th APAN meet on pathology. So, can I share my slides?
Please, sir. Please.
Is it visible? Is it visible?
Visible, sir. Yes, sir.
Just one. Okay, good morning. The topic in this session is role of pathologist in the era of molecular medicine. My screen is visible?
Yes, sir. Yes.
Am I audible?
Yes.
Okay, good morning. Good morning. I'm starting my topic. The topic is role of pathologist in the era of molecular medicine. So molecular medicine is a branch of medicine which deals with understanding of the molecular and genetic basis of disease. And the goal is developing molecularly targeted therapies. It requires integration of knowledge from genetics, genomics, proteomics, and other molecular sciences to diagnose, treat, and prevent disease at the molecular level. Thus, the aim is to make tailor-made treatment for individuals depending upon their genetic makeup, leading to more effective and precise medical interventions. And molecular diagnostics is the rapidly advancing branch of laboratory medicine using various techniques to analyze biological markers at the molecular level, that is DNA, RNA, proteins, and forms the backbone of molecular medicine. So we have witnessed the Human Genome Project, the Cancer Genome Atlas Project, and the Pan Cancer Analysis Project to be completed over past 2 to 3 decades. And there has been a paradigm shift in our understanding regarding the etiopathogenesis of disease towards their genetic basis. And modern pathology includes molecular and genomic approach in addition to the traditional morphologic approach for diagnostic, prognostic, and theragnostic purposes. The Human Genome Project has laid a foundational reference of understanding human genetics and advancing biomedical research. It has brought inherited health factors in forefront. The Cancer Genome Atlas project generated raw molecular data, which on analysis created an integrated genomic and epigenomic view on cancer with individual tumor types. And the second phase, that is the Pan-Cancer Analysis project, has caused further expansion of initial tumor type specific analysis to discover the commonalities and the differences between the tumor types and tissue types. There was generation of data on driver mutation of immune and immune infiltration, and it demonstrated unique molecular alteration for same cancer histology like clear cell carcinoma of kidney, or molecular divergence with relatively homogeneous morphology, which we can get in invasive breast carcinomas. And similarity amongst the carcinoma with similar histology arising in different anatomical sites. So for example, squamous cell carcinoma arising in different parts of body. These findings reflect the interpretation of histologic findings in the context of revealed molecular signature, gene expression, and methylation signature, which can be targeted for the therapeutic purpose in molecular medicine. In this context, I would like to mention that the Cancer Genome Atlas project data are the sole basis of recently emerging molecular classification of so many tumors. Now let's have a look on the gene targets and the drugs used. In the left side, we can see the different target genes, and in the right side, we can see the corresponding drugs applicable in these genetic defects. And these are the examples of molecularly targeted therapy, which makes the treatment more personalized and an essential part of molecular medicine. If we see the immune checkpoint inhibitors, depending on IEC-based detection of PD-1 or PD-L1 as companion diagnostics, we have anti-PD-1, anti-PD-L1, and anti-CTLA-4 drugs, which are applicable in different tumors. And it's seen that the tumors having tumor mutation burden high, like colorectal carcinoma, adenocarcinoma of lung, and malignant melanoma, or the tumors having microsatellite instability high, are good candidates for immunotherapy. Now let's have an overview of the central dogma. On the left side, we can see the different steps, and depending on these steps, we have got the idea of genome, that is the sum total of all genes in an organism. Genomics, the study of sequence of all genes in an organism. Transcriptomics, the study of levels of RNA produced from many genes in a cell. And proteomics, a scientific discipline concerned with the systematic analysis of proteins present in cells at a given time under given conditions. There are other omics too, like metabolomics, is the systematic study of unique chemical fingerprints that a specific cellular process leaves behind. It deals with the study which is limited to the small molecules having their molecular weight 1.5 kilodalton or less. Similarly, epigenomics focus on genome-wide characterization of reversible modification of DNA or DNA-associated proteins such as DNA methylation or histone acetylation. Pharmacogenomics is the study of role of genome in drug response, which may vary from individual to individual depending upon individual's genetic makeup. Now, if we characterize disease molecularly at genomic level, we get copy number alteration of the coding gene, in the form of amplification, deletion, translocation, or gene rearrangement, or there may be mutation of the coding genes. These abnormalities can be found in neoplastic conditions as well as in non-neoplastic conditions. Then comes the dysregulation in gene expression. Polymorphism, so for example, single nucleotide polymorphism in coding region, non-coding region of the genome have got influence on disease susceptibility. Dysregulation of epigenome, which are responsible for expression of epigenetic factors or regulators of chromatin structures like histone marks, and chromatin remodeling complex, which is an energy dependent regulator of transcription factors. For example, SMARC family proteins, SMARC-A4 or BRG1, SMARC-B1 or INI1. MicroRNAs are also there, which generates RNA-induced silencing complex, causing post-transcriptional silencing of coding genes. With the same principle, a synthetically derived RNA, that is siRNA, by targeting specific mRNA can serve as a powerful laboratory tool in knockdown technology, or this can be a promising treatment modality. Studies are going on long non-coding RNA to detect its role in disease like atherosclerosis and cancer. So if we have we see the basic outline of molecular diagnostics for genetic profiling. So genetic testing, what is that? It refers to analysis of DNA to identify changes in the gene sequence or its expression level. This can be done by microscopy-based testing and at the submicroscopic level. So at microscopy-based, we can do karyotyping, FISH, which is fluorescent in situ hybridization, a molecular cytogenetic technique for detection of numerical abnormality or copy number alteration. Copy number alteration can be detected in submicroscopic level also, in genome-wide array, CGH or SNP array, or it can be a targeted screening like MLPA. Mutation detection, when the mutation is known, that means gene is known and the sequence is known, we can do PCR-based methods like allele-specific PCR, ARMS PCRs, etc. Sequencing-based methods following PCR like Sanger sequencing, NGS sequencing or pyrosequencing are also there. This can be even non-PCR, non-sequencing based methods also like allele-specific oligonucleotide hybridization, DNA microarray. But when the causal gene has not been identified or the disease is multifactorial, we detect marker loci, that is the surrogate marker, on linkage analysis studies. Now we can see the other molecular diagnostic tests available. Serial analysis of gene expression provides an idea of global gene expression profile of a particular type of cell or tissue. Proteomics, like expression proteomics, depending on the gel electrophoresis or mass spectrometry based tests, detects and quantify proteomes. Structural proteomics, depending on the X-ray crystallography or nuclear magnetic resonance spectroscopy, can be also there. So metabolic profiling, consisting of separation technique by chromatography or electrophoresis based methods and its subsequent detection by NMR spectroscopy or mass spectrometry are also available, and these are usually followed by data analysis. Immunoassay and Luminex multiplex assay for quantification of multiple biomarkers are also available. Immunohistochemistry, particularly by the use of next generation abnormality antibodies, has become a proteomics-based molecular diagnostics and is playing a vital role in detection of products of abnormal genes, like those genes having genetic rearrangement, mutation of regulator of epigenetic functions, chromatin structure, cell signaling, and chromatin remodeling complexes, which are the major molecular player in development of malignancy and other diseases. Tests for epigenetics and DNA methylations are also available. Locus-specific analysis of methylation, that is direct bisulfide PCR product sequencing, or methylation-specific PCR are there. These tests can be also genome-wide DNA methylation profiling. For detection of histone marks, CHIP, that is CHIP chromatin immunoprecipitation a chip bisulfide methylation sequencing is there, and this can be a global profiling also, which is called BIS chip sequencing. So all this sort of molecular testing is usually done from the small diagnostic samples, which are in the form of small biopsy or cytology samples. But sometimes when the patient is seriously ill and undergoing treatment, on follow-up, the similar type of molecular tests cannot be done from this type of material because it is difficult to procure this material. Then circulating, these similar tests can be done from circulating tumor cells or circulating tumor nucleic acid, exomes, or tumor educated platelets. And the samples are blood, urine, CSF, and saliva. And this form of diagnostic modality is called liquid biopsy, and very much applicable and useful in this situation. Multiplex assay for molecular identification of microorganisms and detection of bacterial resistance are also there. These type of assays are part of molecular diagnostics and are based on PCR, FISH, immunoassay, mass spectrometry, next generation sequencing, etc. Now coming to the pre-analytic factors for molecular diagnostics, which is a concern for pathologists. Pathologists will have to take care of adequate amount of tissue, extracted DNA, RNA quantity, and their quality. So if we consider the quantity, we see that for 500 gene panel test, we require 30 nanogram of DNA, and one human diploid cell contains 6 picogram of DNA. So from there, we can calculate that 5,000 human diploid cell is required for that comprehensive genomic profiling. Considering the quality, the pathologist should take care of cold ischemic time, use a proper fixative time of fixation. For example, for biopsy, it is 6 to 48 hours, and for resection specimen, it is 24 to 48 hours should be assured. And they should take care of storage time of the blockage, that is less than 3 years, and storage time of the cut section, that is less than 2 months, to get the best result of molecular testing. Now coming to the integration and analysis of molecular diagnostic. So different information of omics technology are available in different databases. Proper knowledge of bioinformatics are therefore essential. TCGA also generated huge digital image data, which are the basis of several studies to investigate genotype-phenotype correlation and revelation of histologic biomarkers of patient outcome. Digital pathology is expanding with a focus on using image analysis. Its application got US FDA approval, like Ventana image analysis system for HER2 PD-L1 scoring and other systems for ERPR screening, etc. So there is production of big data and there is dealing of complex problems. So we need to generate idea for about the data-driven disease prediction and automate model building. Here lies the utility of machine learning. So artificial intelligence and neural networking along with machine learning will lead to analysis of big data and its interpretation, which helps in the diagnosis and of genetic disorders, infectious disease, and cancer. Precise identification of pathogens and their resistance profiles thus guide the choice of drug and dose on an individual basis. So in this era of molecular medicine, a pathologist will have to be not only the expert in routine morphological diagnosis, but he or she will have to be welcoming in testing, adopting and utilizing new methods of molecular profiling, applying knowledge of biomarkers discovery, pharmacogenomics, metabolomics, machine learning, and artificial intelligence for tailor-made therapeutic decision. And that's the ultimate goal of molecular medicine. Here is my references. I am thankful to the resource persons, Dr. Shambit Mohanty, Dr. Arindam Ghosh, Dr. Arithri, and Dr. Banani Roy. So thank you for my patient hearing.
Thank you so much, Anup sir, for your elaborate insights on this molecular aspects of pathology. Sir,
thank you.
we are indeed grateful to you for your insights. Now I would invite Professor Dr. Sonia Gaun ma'am from ESI Joka Medical College, Kolkata. She is the professor of pathology at ESI Joka Hospital, and she has done enormous works in cytopathology and histopathology. And she will be delivering her talk on artificial intelligence in pathology today. Ma'am, over to you.
Thank you, Professor Asitava. Thank you for your kind words. Good morning, everyone. So I will just share my slides first. And in the outset, I would like to thank the organizing committee of this APAN58 Pathology for inviting me on this virtual scientific platform, which is yet another example of artificial intelligence in our daily teaching learning activities as well. So it is corroborating well with my today's talk of artificial intelligence in diagnostic pathology, a dawn of new era. So we know that artificial intelligence is all around us and in such a way that we are not even aware of it. Amazon's Alexa, Google's Assistant, Apple's Series are the smart assistants which we are leaning on to every day, many times of a day. And in healthcare sector also, from cardiology to radiology to oncology to diagnostic pathology, from artificial powered chatbots to virtual assistant to personal health companions, and improving population health management and operation to strengthening innovation through better care delivery and care management, artificial intelligence is all around us. So this artificial intelligence revolution in diagnostic pathology started with John McCarthy when he coined the term artificial intelligence in 1956. And the first revolution of artificial intelligence in pathology after computerized image analysis and deep learning was started in 1988 with the advent of convolutional neural network by Jan Bleekum et al., followed by whole slide scanners advent in 1990s. Now, after the whole slide scanners were invented, it was TriPath, the first company which was approved by the FDA for bringing on the automation in pap smear screening. Now, after that, the second revolution occurred with the advent of NGH, which was widely adapted by the Pathologist Society. Now, the third revolution of artificial intelligence in pathology happened with the advent of IntelliSight in 2017, for which Philips received the approval by FDA for a digital pathology whole slide scanning solution. In 2018, with the advent of IDX-DR, FDA permits the first medical device using AI to detect diabetic retinopathy in adults, followed by Page Prostate in 2021 by FDA authorized first AI-based software to detect prostate cancer. Now, a brief review about role of AI in diagnostic pathology. Now, machine learning predictions are based on input data and algorithms, as explained by my previous speaker, Professor Anup Kumar Bholar. And deep learning have three layers: the input layer, the multiple hidden layers, and the output layers, which actually reconceptualizes the human neural connections. And it is accepted in a wide variety of image analysis and segmentation of tasks. The segmentation of tasks can be only in object identification of a cell, or it can be a complex task where image pattern analysis are used and utilized for diagnosis, for prognosis, as well as for therapeutics. Now, for these, machine learning algorithms has to be developed, which are domain-inspired features, or it can be domain-agonistic features. For domain-inspired features, pathologists or oncologists' inputs are utilized, and they are very challenging to make, because a pathologist or oncologist basic fundamental knowledge as well as advanced knowledge about the pathological process and its manifestations needs to be there. For domain-agnostic features, image characterizations across several diseases can be better depicted, such as nucleus and glandular shapes and size, tissue orientation, texture, and architecture. So application of AI in diagnostic pathology starts from the diagnostic application, which utilizes whole slide imaging technology to give a better accuracy, increased workflow efficiency, and better inter-reader reliability. Now, example of whole slide imaging is for quantification of biomarkers such as Ki67 and PDL1, or automated identification of micrometastases in lymph node sections for breast and colon cancers, and also in developing scoring and grading system for prostatic cancers and breast cancer. Now, worth to mention here is the Chameleon 16 challenge, which was the first challenge to be adopted and seen by using AI in histopathology. Now, for this, diagnostic assessment of deep learning algorithms for detection of lymph node metastasis in women with breast cancer study was carried out, and it was seen that deep learning algorithms achieve better diagnostic performance than a panel of 11 pathologists participating in a simulation exercise designed to mimic routine pathology workflow. Another key milestone was the Panda challenge, where developers where 1,219 participants across 65 countries, they joined their hands together and studied 10,616 biopsy for the development of AI tool, which can score and grade the prostatic carcinomas and give a better prediction for the Gleason scoring system. The study was quoted by Bulletin et al. In Nature Medicine and titled as Artificial Intelligence for Diagnosis and Gleason Grading of Prostate Cancer, the Panda Challenge. Now, currently, CNN is the most widely used deep learning algorithm, which is a deep feed-forward network consisting of multiple sequential layers, or you can say conventional sheets. Now, Kuchar et al. Has done this image analysis with deep learning to predict breast cancer grade, ER status, histological subtype, and intrinsic subtype, and published the study in NPJ Breast Cancer in 2088. And they can, with the help of this convolutional neural network tool, they can actually divide the cases into the high, intermediate, and low-grade tumors. Now, the second application, which is the predictive and prognostic application, can be utilized in diagnostic pathology for detection of spatial organization of tumor-infiltrating lymphocytes, and accurate prognostic models have been made to study this predictive and prognostic application. Now, these tools can directly link images with several features of tumors and the surrounding microenvironment and genetic profiles with survival outcomes and treatment responses for adjuvant and neoadjuvant therapy. So computer-extracted features of cancer nuclei from H&E stained tissues and integrating these myriad morphological features can actually make a single prognostic index, which is quite difficult for humans to make. Similarly, tumor infiltrating map generation was done with an H&E image slide, and this whole image is further subdivided into 5,455 images, and 13 cancer types can be detected with this tool. And interestingly, these TILs can be divided into and categorized into 3 types of TILs. Like categorized TILs as over or under predicted lymphocytes, group TILs based on the accuracy of initial prediction, review TILs and adjust thresholds from a sampling of 8 TILs plus group. And these TIL maps, which are generated as an output layer, is the TIL maps for clustering and analysis. These tools can also be utilized for the molecular and genomic profiling of a tumor. So there are models which can predict the SPOP mutation status in prostatic cancers, and there are models to detect microsatellite instability in colorectal carcinomas. Now, deep learning for the detection of microsatellite instability from histology images in colorectal cancer is documented by Emily Eshel et al., where they have categorized and further subdivided the whole slide image into different 10 by 10 tiles, and they have divided into MSI deficiency MMR as well as microsatellite stable proficient MMR. And they have determined that MSI determines whether patient with colorectal carcinomas respond exceptionally well to immunotherapy or not, or whether there is a potential to provide immunotherapy to a much broader subset of patients with gastrointestinal cancers. Now, in research and education training, the AI tools provides very helpful annotation tools with ease of consults and dynamic interface for the learning. The annotation tools can help a trainer or the residents to pan, zoom, and mark the areas of interest while having a dynamic, interactive learning platform. So these interesting interactive learning platforms can be developed with the help of WSI and utilized at conferences, virtual workshops, presentation, and tumor boards. The Ohio State University has developed a digital cockpit tool using Philips integrated management system, where they have many hundreds and millions of image stored in a digital platform, can be utilized anywhere from anywhere and across multiple institutions as well. Laboratory information system or breaker or synoptic reporting templates or integration of whole slide images into the laboratory information systems can also be utilized as an AI tool for teaching learning experiences. Visoform has developed an AI tool which can enable swift detection of isolated tumor cells metastasis in lymph nodes in a very difficult cases. And you can mark that area of interest also with this type of tool while taking a teaching session for the residents. Now, in the drug discovery and development, for prediction, to know the prediction of response to anti-PDI antibodies, nivolumab, in late-stage non-small cell lung carcinomas, these tools can be utilized. Now, immune checkpoint inhibitors, combining AI with digital pathology to stratify patients based on likely therapeutic benefit. AI tools such as handcrafted ML approaches can also be used to predict therapeutic responses to targeted agents, immune checkpoint inhibitors, and chemotherapeutic drugs. Now, there are many advantages of artificial intelligence, and hence comes the roadblock and challenges in implementing them too. Now, the first is the ethical principles involved in utilizing these AI tools by the humans. And it is said that fair guiding principles should be in place for scientific data management and stewardship. That data should be easily acceptable, it should be independent from the operator, and it should be reusable. Now, these algorithms which are made and utilized by the AI tools has to be vigorously screened uh, for validation, and it should be a multi-institutional validation. And overfitting, where AI algorithm trains on one data set have a limited applicability on another data set, should be avoided as far as possible. Interpretability and the black box problems often occur when utilizing these AI tools. So when DL algorithms are unable to demonstrate how they arrive at a specific conclusion, it is the black box problems which arises. So despite obvious advantages of accuracy and efficiency of interpretability is a huge roadblock for implementation of these AI tools. Quality of data should be assured while developing the algorithms for these AI tools, and also the quantity of data has to be standardized. Now, the computational system should have a very high speed and high-end computational system should be there for as well as for data storage, and a cost-benefit ratio should be looked upon while developing the AI tool. It is important to have a powerful high-specification hardware for processing and analyzing the images. Technological issues are always there when we are using WSI in our day-to-day practice. WSI for a slides, for small biopsy, it takes about 1 to 5 minutes to store the images in WSI, and for bigger biopsies, it takes about 15 to 20 minutes to scan the whole slides. So it takes a lot of time. And again, the overfitting, when we are developing these algorithms, the overfitting factor has to be looked upon. There should be stringent regulation, reimbursement, clinical adoption, and the avoidance of black box problem. The regulation must be very stringent, approved by the FDA or other regulatory bodies. Now, last but not the least is about the pathologist's dilemmas, whether to use these AI tools or not to use. Apprehension about the change in the workflow using AI tools puts the pathologist into a dilemma of whether we are using it or not. But incorporation is actually a win-win situation in the clinical workflow of these AI tools. Now, after the future directions and opportunities which we can have is the after 2017, after getting FDA approval of Philips whole slide scanner in 2017, and in 2019 the development of a digital cockpit by Ohio State University Wexner Medical Center, and in 2020 with the advent of top light sheet microscopy, where there is no need to actually scan the whole slide, and latest in 2020, the advent of Muse microscopy, which use ultraviolet rays for surface excitation. It can actually circumvent the need of tissue processing and storage of the slides in the huge database. And options.
Dr. Sonia has disconnected.
Okay, so maybe we move ahead with the next presentation. Dr. Priyanka. Priyanka, ma'am?
I'll move ahead with my presentation.
Yeah, so I welcome Dr. Priyanka, ma'am. Dr. Priyanka Gogoi is Associate Professor in Transfusion Medicine at All India Institute of Medical Sciences, Guwahati, Assam. And she'll be talking on a different domain of pathologists where we have to sometimes intervene, and which is a domain of transfusion medicine, which is a very novel domain. And sometimes it is very challenging for us pathologists to intervene and make therapeutic decisions for patients. So over to you, Priyanka madam, for your presentation.
Thank you, Dr. Asitaba, for your very kind introduction. At the outset, I would like to thank the TEMDEC team for giving me the opportunity to present my slides today. I'd like to share my slides here. So I hope my slide is visible.
Yeah, it's visible, madam.
So I'll be talking on a topic which in recent times have gained much focus, which is patient blood management. Right. So the life-saving value of a transfusion cannot be denied in certain circumstances. For example, when you have an exsanguinating trauma patient, an RBC transfusion will allow adequate oxygen delivery while facilitating repair. A platelet transfusion in a patient who is thrombocytopenic will allow the patient to complete his therapy while reducing the risk of hemorrhage. Similarly, a plasma transfusion can correct significant coagulopathy and reduce the risk of bleeding. In this extreme circumstances, the value of a transfusion is obvious. The risk associated with the transfusions are minimal in comparison to the benefit, and any complication arising out of the transfusion can be managed as a part of the patient's overall therapy. However, more often than not, transfusion orders are not always received in these circumstances. And a lab value, for example, a hemoglobin value, a platelet count, or a PTN INR forms the rationale behind a blood order. However, in the case of any therapy, particularly when we are talking about a prophylactic therapy, it is essential that we weigh the benefit that the therapy intends to provide against the risk which the therapy itself has. So in the case of transfusion, this complications translates into transfusion reactions. So the most of the common reactions, fever, urticaria, these are considered as very minor complications, and most of the times these are overlooked by most clinicians. Next, we have the most dreaded complications, which are the transfusion-transmitted infections. Now, this complication in recent times, because of the increased focus on product safety, has minimized, and most clinicians would not have had the experience of this facing this type of complications in their patients. Again, these are overlooked as a result. Now, the focus has shifted from transfusion related infections to the non-infectious complications. So we have, this is a short report which shows that the non-infectious blood transfusion reactions like TACO, TRALI, and TREAM, they're responsible for almost 66% of transfusion-associated mortality in the world. And again, we have the problem of bacterial contamination of blood products, that most commonly seen in platelet components, since these are stored at room temperature. And these are transfused most commonly in patients who are otherwise very critically ill. So you have patients who are already febrile, who already have comorbidities. Hence, the transfusion-related sepsis in these patients are often overlooked, right? Next, we have the cost. The cost of transfusion also cannot be overlooked. Physicians base their therapeutic decisions based on patient's outcome and not on cost. However, in recent times, it is essential that we also consider the cost of a transfusion. While we just look at the cost of a unit of blood, which is fully tested, it may look like a great bargain in terms of the therapeutic benefits that the unit of blood would give to the patient. However, if we consider all the cost, we tally all the cost which is related to the processing of the unit, the storage of the unit, the transportation of the unit, it is a staggering cost. And if this cost cannot be justified by the benefit which the patient would achieve by the transfusion of that unit, it needs to be reconsidered, and any alternative therapy which offers similar or if not better outcomes for the patient needs to be considered. So in the past 4 decades, the realization that transfusion itself has a lot of inherent risk has led to many improvements in testing of components, in the selection of donors, such that this risks have been considerably reduced. However, the realization that a similar focus on bedside transfusion decisions have not been given has given rise to the concept of optimal blood use, which focuses on improving transfusion decisions at the bedside. The concept that our own blood is still the best thing to have our veins has led to the development of blood conservation techniques in mostly the surgical side, where we have techniques such as we have minimally invasive surgeries, we have surgeries with minimal blood loss, we have techniques such as cell salvage, use of AIH or acute isovolumic hemodilution. So all these techniques have been developed to reduce the amount of transfusion that the patient would require, and hence reducing the inherent risk that a transfusion carries. Underlying all these efforts is the broader concept of what we now call as patient blood management. So in the next few minutes, I will be giving you an overview of the concept of what PBM entails, what are the 3 pillars of PBM, what are its benefits, and we draw a conclusion based on this. So now if we talk about patient blood management, we have to understand that this is a very systematic, very evidence-based, and very patient-centric approach. And this is all aimed at improving a patient's outcome. PBM manages, it addresses the problems of anemia, it addresses the problems of blood loss and coagulation in the patient, and it does so by managing a patient's own blood. In doing so, PBM goals to promote patient safety, and it takes into account the patient's decisions so that the patient is empowered in his decision making. It reduces the utilization of healthcare resources, expenditure, transfusion dependency, and the risk of transfusion. So this is in gist what patient blood management implies. So the central tenet of PBM is utilizing every available measure that is there to protect and manage a patient's own blood. And this system is very individualized. It is tailored to the needs of the individual patient. And therefore, we have the 3 pillars of PBM. So the first pillar is optimizing erythropoiesis. The second emphasizes on minimizing bleeding and blood loss. And the third pillar of PBM talks about harnessing and optimizing the physiologic tolerance of anemia in the patient. So if we go into the first pillar, which is optimizing erythropoiesis, let us have a look at the burden of anemia. So this is the WHO data, which shows that around 2.9+ billion people in the world suffer from anemia, and almost half of them have iron deficiency anemia, and another half have micronutrient deficiency, which can lead to anemia, right? And anemia has been seen to have a very bad impact on the patient's morbidity and mortality. Partially overlapping with this population, we have another 600 million people who have problems of chronic or acute blood loss or bleeding disorders. And this, again, individually, if we see, this population of people, again, have an increased risk of morbidity and mortality in terms of increased complications, increased hospital stay, increased ICU admissions. Now, together, this represents a large population of a largely preventable, yet greatly underestimated problem, causing great effects on the patient's outcomes as well as a burden on the healthcare system. So this is another slide showing you the prevalence of anemia and the different causes which leads to anemia in the general population. And this is a slide which shows the prevalence of preoperative anemia on the patient. And as we can see from here, it ranges from almost 15% to 31%, whereas the prevalence of postoperative anemia has been seen to be almost 51%. So what does this entail? What does this translate into in terms of the patient's outcome? we can see that preoperative anemia, this is a systematic analysis which has been done, and this shows a composite 30-day or in hospital mortality after surgery. So as we can see from here, a preoperative anemia in these patients is related to a greater incidence of a 30-day mortality in patients after surgery. So what is the solution for this? As pathologists, we do have a role in this, right? So a very simple pathological test like a peripheral blood smear, a transparent saturation rate, a ferritin level, this can help the clinicians to develop a simple algorithm which can detect a preoperative anemia or a pre-admission anemia and correct it so that as and when the patient is admitted, the need for a transfusion is mitigated in these patients. This is just a sample, and each hospital can sit together because PBM is not a single department approach. It is a multicentric approach. So a multi-pronged approach. So different specialties can come together, form their own protocols, and implement PBM in their own settings. This is just a revisit showing the dependence of erythropoietin and iron on the whole process of erythropoiesis. So while oral iron therapy might not serve the purpose of correcting anemia before a planned surgery or planned admission, intravenous iron or erythropoietin therapy serves the purpose. So this is a study which had been carried out, which shows the efficacy of preoperative IV iron in reducing the transfusion rates in patients who have been admitted later on. This is a forest plot showing the efficacy of giving preoperative erythropoietin in these patients. So are these therapies safe? Yes, studies have proven that these therapies are safe, and this is a study which has been done by Hatchell et al. In 2018, and it shows the percentage survival in patients who have been given therapy beforehand and patients who were not prepared before therapy, and the survival rate is seen to be better in patients who have been prepared with iron or erythropoietin and correction of their anemia before their planned surgery. Now moving on to the second pillar of PBM, which is bleeding management, and as has been stressed from before, this is a very personalized and precise. This has to be very personalized and very precise in managing the patient's blood loss. Different strategies have been developed to optimize coagulopathy in these patients, and this is just a sample which can be utilized in the hospital's own setting. So we have preoperative management of coagulopathy, wherein there should be an algorithm which should be developed for management of patients who are on oral or parenteral anticoagulation and or antiplatelet therapy. Then hemostasis management in hospitalized patients can be undertaken by maintaining the physiologic conditions of hemostasis by maintaining the body temperature above 36 degrees centigrade, a pH above 7.2, ionized calcium levels above 1.1 millimole per liter. We could also have point-of-care diagnostic in coagulopathy. This could be there in your OT theaters, where we use viscoelastic methods or aggregative methods to determine whether the patient really needs an FFP or a platelet transfusion. Then we could develop a coagulation algorithm for administration of blood products, use of alternatives to blood transfusion. For example, the use of tranexamic acid in orthopedic surgeries. Topical tranexamic acid should have been shown to have a better, in fact, effect on the patient's morbidity and mortality vis-a-vis a transfusion. Right, so we could also have empiric therapy of platelet dysfunction. For example, desmopressin could be used. So all these alternatives to transfusion could be looked into to mitigate the need of a transfusion in these patients. So the recommendations of PBM are basically using blood-sparing surgical techniques with meticulous hemostasis to reduce the event of blood loss in these patients. Use of cell salvage, this is a bit controversial. The use of cell salvage is greatly recommended. Autologous transfusion, I was talking about autologous transfusion. So that is now a controversial subject. Earlier, it was much recommended, a preoperative autologous transfusion. However, it has been seen that this can lead to anemia. And anemia, again, will have an increased risk of morbidity and mortality in this patient. So that is not much recommended these days. So the use of tranexamic acid, advanced individualized and goal-oriented coagulation management, and monitoring the use of coagulation factor concentrates. So all these recommendations cover the second pillar of PBM. The last pillar of PBM talks about harnessing and optimizing physiologic tolerance of anemia, which can, and restricted transfusion is one of the modalities which can be used to implement the third pillar of PBM. So when we talk about restrictive versus liberal transfusion, studies have been going on as back as 1999, wherein it was the survival rate in patients were seen after giving a restrictive transfusion strategy versus a liberal transfusion strategy. And it was seen that survival is much greater in patients who have received a restrictive transfusion strategy versus those receiving a liberal transfusion strategy. So that restrictive transfusion strategy not only have an effect on the survival of the patients, it also has an effect on the overall complications which a patient can face during their stay in the hospital. So if you look into the different systems, we have the cardiac, the pulmonary, the infectious, hematologists, gastrointestinal, all these complications were seen to be much lesser in population receiving a restrictive transfusion strategy versus those receiving a liberal transfusion strategy. And this effect, this good effect, was seen in patients who were critically ill and those who were younger. So these patients it was seen that these patients had a greater benefit of receiving a restrictive transfusion strategy compared to patients who were less ill or who were older in age. Now, if we talk about the number of transfusion units which a patient has received during this stay, and we compare it to their overall mortality and morbidity, it was seen that as the number of transfusion units increased, it was seen that there was a percentage increase in the mortality seen in this patient. So there was almost a 10% increase for each 10 units of RBC transfused, and this reached to almost 50% mortality after a transfusion of 50 RBC units. Similarly, the number of units transfused had also an effect on the number of morbidities that was associated with the hospital stay. So what are the transfusion thresholds for guiding red blood cell transfusions? There has been a lot of studies and evidence suggests that for most transfusions, a restrictive transfusion strategy would imply giving an RBC transfusion when the hemoglobin level is less than 7 gram per dl versus a liberal hemoglobin, which translates to giving a RBC transfusion when the hemoglobin level is less than 9 gram per dl. This is a sample transfusion guidelines. Although the guidelines or the evidence for red cell transfusions are well established, similar guidelines for platelet and plasma are not as strong. However, this simple table can be followed at each hospital and they can adopt it based on their evidence. So for RBCs, as I was talking about, hemoglobin less than 7 gram per dl in most cases suffices for transfusing a hemoglobin for a PRBC unit. For platelets, platelet count less than 10,000 threshold is appropriate for hospitalized adult patients. So we can relax the platelet count to almost up to 10,000 per microliter, wherein we will think of giving a transfusion. Right, and for major surgeries or bleeding or invasive procedures, this count can be increased to almost 50,000. For plasma, INR greater than 2 is recommended. Perioperative platelets with excessive microvascular bleeding or coagulopathy in the absence of heparin or in patients undergoing minor invasive procedures. But for neuroaxial surgery or bleeding or procedures with increased bleeding risk, an INR greater than 1.5 threshold is considered wherein you would infuse plasma to these patients. For cryoprecipitate, fibrinogen less than 80 to 100 milligram per DL is the recommended value, after which you will think of giving a cryoprecipitate transfusion. So if we have to summarize the three pillars of PBM, for the preoperative period, for pillar 1, which is optimizing red cell mass, the primary aim is to detect and treat anemia and iron deficiency, or treat any other underlying cause of anemia, whereby we optimize the hemoglobin levels and we cease medications. In the intraoperative period, this would entail timing the surgery with optimizing of erythropoiesis and the red blood cell mass. And in the post-operative period, we have to manage anemia and iron deficiency, manage medications, and potential interactions with other medications. For optimizing or minimizing the blood loss, the pillar 2, in the preoperative period, we have to identify, manage, and treat bleeding or bleeding risk, minimize phlebotomy. This is one of the major factors which has been seen to lead to anemia, especially in pediatric patients. So minimizing phlebotomy is one of the most important strategies and easy strategies which we can adopt to decrease the risk of transfusions associated complications. Plan or rehearse the procedure so that there is minimal blood loss. During the intraoperative period, meticulous hemostasis, surgical or anesthetic techniques needs to be used, use of cell salvage techniques, avoid coagulopathy, and patient positioning and keeping the patient warm, and use of pharmacological agents like tranexamic acid. In the post-operative period, we have to monitor and manage post-operative bleeding, keep patient warm, minimize phlebotomy again, and awareness of any drug interaction which can lead to bleeding in these patients. Then we have the third pillar where we manage anemia. The patients in the preoperative phase, the patient's bleeding history and develop management plan accordingly. Estimate the patient's tolerance for blood loss, optimize cardiopulmonary function. During the intraoperative period, again, we have to optimize the cardiopulmonary function, optimize ventilation and oxygenation, and use of restrictive transfusion strategies. Lastly, but not the least, we have to maximize the oxygen delivery to the patient, minimize use of oxygen, treat infections promptly, see the patient's tolerance of anemia, and again, adopt a restrictive transfusion strategy. So this is in summary, the three pillars of what PBM talks about. Now, what happens when we adopt a PBM into our hospitals? So this is a snapshot showing the clinical and economic outcomes of Western Australia patient blood management program. So Australia was one of the first countries to develop the PBM into their healthcare system. And as we can see, if we see in terms of improved patient outcome, we can see that adoption of PBM from 2008 to 2014 led to a decrease in mortality of almost 28% in patients, reduction in infection of almost 21%, reduction in AMI or strokes to 31%, and the length of stay in the hospital reduced by 15%. There were improved indicators, key program indicators, which showed preoperative anemia decreased from 21 to 14%. The pre-transfusion hemoglobin decreased from 79 gram per liter to 73, and single unit transfusion significantly improved in these patients from 33 to almost double 64%. Plus, there was reductions in the units of blood transfused. So 41% reduction in red blood cells transfusion, 47 in plasma, and 27 in platelet transfusions. And if we translate this into the cost that the healthcare system had to take, so we can see that the product cost savings was a staggering 18.5 million, and activity-based cost savings increased from 80 million to 100 million. So if we have to summarize the benefits of patient blood management, we can see it in terms of reduction in transfusion rates, reduction in the number of units transfused per patient, reducing in the length of stay in hospitals, reduction in major complications, and reduction in the overall mortality in these patients. In conclusion, there is a tendency to, confuse PBM with rational use of blood components. While rational use of blood components is one of the central tenets of PBM, PBM is a much broader concept. It is not centered just on transfusion of blood components and certainly not on red blood cells. It is centered in patients, more specifically patients who will undergo a major medical or a major surgical procedure and which will put them at risk for complications or mortality. It is not an offensive against producers of blood components. Rather, it aims to improve the outcomes of patients at risk through the optimization of the patient's condition before, during, and after the procedure. And only when it is absolutely needed, the implementation of an effective blood transfusion strategy. Thank you all for a patient listening.
Thank you, ma'am, for your elaborate talk on patient blood management, which is a very pertinent topic. So we have had a very interesting discussion on molecular pathology, artificial intelligence in pathology, and patient blood management. Now we move ahead to a different domain in pathology, which is teaching methods, which are innovative teaching methods in pathology. And for that, I would invite Professor Dr. Yokurin Khongla, Madam. She is a professor in pathology at NIGRIM's Northeastern Indira Gandhi Institute of Health Sciences at Meghalaya, Shillong. So, Madam, I would now hand over the platform to you for your presentation on innovative teaching learning methods in pathology.
Thank you, Dr. Asitawa. Greetings to all of you, and I thank the organizers also for having me. So I know that Dr. Asitav has said innovative methods. This is through actually my experience. So there will be situations where you might not agree with me, but I am going to tell you how we teach pathology and how children can learn through experiencing pathology. So these are my objectives. First, we have to understand what is teaching and what is learning. And
ma'am, ma'am, you have to share your screen, ma'am.
Oh, I thought I had shared the screen.
No, ma'am, it's not visible.
Okay, just hold on, please.
Yeah,
yes.
Yeah, ma'am. Yes.
Call Dura Ajira. I'll just stop share and I'll reshare.
Yeah.
Just hold on. Share. Wait. No, this one.
Okay.
Is it visible?
No,
Not yet, ma'am.
Now you have to share it.
Where is it? I'll call Jina.
Yeah, go call her.
Jira? Just mute.
Yeah, it's visible, ma'am.
Okay. Okay, so these are my objectives. I'm very sorry for that. So first we'll understand what is teaching, what is learning. And then the second is to look at the mindset of the educator and the student and what are the strategies we can help to learn pathology. So this is one thing which I really, my slide is not moving. My slide, okay.
Yeah, it's moving, ma'am. Yeah,
okay.
Moving.
Fine. So this is a favorite cartoon of mine to distinguish teaching from learning. So Max said, I taught the dog how to whistle. And the friend says, I don't hear him whistling. And his friend says, I said, I taught him. I did not say he learned it. So basically, learning is a behavioral change. There should be a behavioral change. So now how do we expect the students to learn pathology? Here I am talking about MBBS students. So if you notice, according to the National Medical Commission, Indian medical graduate, also we have to be good clinicians. That's the first thing. So in pathology, we should teach students to be good clinicians, not to be good pathologists. If we get that into our heads, then we will teach pathology the way it should be taught. So being a good clinician, how to take relevant patient history, how to do physical examination based on the history, and how to arrive at the clinical diagnosis. All this is clinical reasoning, and clinical reasoning can only arise from a solid understanding of pathology for the undergraduate students. So how do we teach then? We teach pathology as the basis of all disease. We have to show the medical relevance, the clinical relevance of what we are teaching. When we show them gross specimens and we show them microscopic changes, we have to teach them how to correlate the altered morphology with the patient's signs and symptoms. Like recently, I had a viva, and there was an intestinal obstruction due to a tuberculous ulcer. So I asked the students, so how do you think the patient will present with this kind of a thing? They have identified it's a large intestine, there's an ulcer, there's an obstruction, but what are the clinical features? So the students will really, learn to clinically correlate the gross, and they will try to understand that. So students, we have seen that students, they easily memorize slides without actually understanding what is the reasoning behind those slides. So these are the things we should not allow to happen. And I believe that as pathologists, we should not push so many gross and microscopy on the students. We should teach enough to make them understand the clinical reasoning behind those gross and microscopy, to make them interested and to make them understand the value of the lab. So how do we teach them to learn? Now, we should not give information-loaded lectures. We should give concept lectures, because everything is available. These students are new generation students. They have everything, all the videos, images, much better than what we teach in class. So if we give them a very good concept, that is where they will appreciate. Not information-loaded classes. Make the classes short and interesting. And mainly share clinical cases to generate interest and clinical relevance for the classes. And if we can do that, if we as teachers can do that, and we believe that we are not the sole sources of information, they have all the information available, but if we can spark an interest and make them understand the clinical relevance, we are encouraging them to do a self-directed learning. So this will continue if they are motivated and they are interested. Self-directed learning, the word itself, directed, means that we will be actually facilitators. So this is an example when we start those general pathology, which are quite dry topics. But if we show them the clinical relevance behind learning cell injury, how will this wound heal? How will this wound heal? We show them clinical pictures and we talk about these subjects, then it will be interesting for the students. So how do we do nowadays? Like what I was saying, change in the mindset of the teacher. When we study too much, we teachers tend to talk too much also. So when I do small group discussion, like I said, you might not agree with me, but I do not study purposely, so that in small group discussions, I bring out clinically relevant things. I tell them, see, this is a clinical situation. How does the history go? How does the physical examination go? What investigations will you do? I'm trying to lead them into that. So I am facilitating. I'm not teaching them, because they can learn everything on their own. But we have to make them good clinicians. We have to give them the concept of finally what they have to learn. So that is facilitating teaching. So first, we teachers have to learn to be facilitators, not to keep on teaching and to believe that we are the ones who know it all. Most of the students now know a lot, except that we have to clear the basic doubts for them. There is something known as a flipped classroom, and where we give the topic before we teach them, and then we come and discuss together. But the fact remains that I don't know whether other people face this. We also face it. Some students will be very interested in it. Most of the students will not. So we have to change the mindset of the students. How do we do that? That's a big challenge. Most of the students will not come prepared. So, and the students who are intelligent, they will come prepared. So we have to look at those students who are not very willing. And then we have to ask them clinical questions and spark an interest in them. So in a lecture also, 45-minute lecture, I tend to, every 15 minutes, put a clinical vignette, MCQs, so that we, because everybody actually, the attention span is hardly 10 to 15 minutes, and then they get lost. So if you put a question in between your lecture, you sort of wake them up and bring them back into the path. And immediately you can, if they give wrong answers, you can immediately correct and give the reasoning behind the answer, which is the most important thing. Nowadays, there are a lot of learning management software where we can do the attendance and assessment. So not all doctors are pathologists, but we should ensure that we teach the value of pathology. And very important is how to teach them to collect, to store, to transport samples, to analyze, interpret data, and teach them the updated laboratory tests. So this is one of the examples. We give these kind of the real forms. They love it when we give them real forms, not in a PPT. We give them to hold these forms. We write the values and we ask them to interpret. So these are two situations. You'll notice here I've just put 10,000 total count. So this is neutrophilia. And here 16,000, I'm teaching them that this is neutrophilic leukocytosis. So this is learning pathology through experience. It's known as experiential learning. We emphasize and we teach them active problem solving, critical thinking abilities, involve students in the teaching and learning. So that was about undergraduate teaching. Postgraduate teaching, I know all of you are experienced. We do this. I'm sure everybody does this. Now, when we do daily reporting, it is experiential. What is important is for PGs to understand the clinical value. So every time there is something with inadequate clinical information, we tell them, go to the ward, see the patient yourself, read the files, come back and give us the information. That is very important. The other things are things which you do and other things which help them to improve their clinical, to be a good clinician. Even if you come to be a pathologist, you have to be a good clinician first. So we make them attend multidisciplinary teams, mortality meetings, clinical grand rounds. And of course, these thesis presentation and all are part of the NMC protocol. So another thing which we found very important is for them to understand quality indicators in the lab. We recently got NABL accreditation, and we often have discussions on NABL when we make the PGs sit there so that they understand what are the pre-analytical, analytical, post-analytical, all these things, so that they learn through experience when they see the technicians discuss this. And there are so many things which is mandated: the basic life support, advanced cardiac life support, the good clinical practice, ethics, and basic course in biomedical research. All this is included in postgraduate teaching. One thing which I introduced in our postgraduate teaching is this. There are technical issues. We tell the students that they should go and learn from the technicians, but believe me, it doesn't happen because the students do not have time. The postgraduates do not really have time during the day to learn from technicians. So now I have put up these kind of things, click these kind of things and put questions. And we ask the students, sometimes during reporting, we ask these questions and they turn to learn the technical issues, how to correct it from these kind of questions. So this is something which I felt was required in the postgraduate thing. And this is also a slide which was not dehydrated properly. So these are questions and answers for that. And this is how post-correction, how it would look like. So this is, in conclusion, this is by Benjamin Franklin. And if you notice, it starts with teach and it ends with learn. Involve me and I learn. And learning is a behavioral change. This is an article which I got from Pathology 10. It is a beautiful article for undergraduate teaching. They took the words out of my mouth in this article. It was really nice. I would love it if you read it too. And thank you so much. That's the end of my talk. Thank you, Dr. Asitava.
Thank you so much, ma'am, for your wonderful thoughts on how to innovate so that we make students learn pathology. Ma'am, if you, thank you for stopping the screen sharing. I'll just share my screen for the last presentation, and which will summarize why, what is the importance of pathologists in the scenario of in the clinical context, basically. So I'll just be very brief. So these are two pictures. This is a picture of basically Mars, the Greek god Mars, and this is the picture of the Greek goddess Venus. And the context of today's talk is pathologists are from Venus and clinicians are from Mars. Now, this is basically adapted from an article which was published in Archives of Pathological Laboratory Medicine. This was published in the year 2000. The context says the pathologists have a long-standing alliance with the clinicians, and their interdependence has become more and more complex. However, this relationship suffers due to a lot of factors. And factors which affect this relationship as lack of trust, poor communication, imbalanced priorities, inability to or unwillingness to understand and respect each other's expertise. An ideal pathologist in the eyes of a clinician is one who promptly generates reports, does not bother and fuss about the history or background of the patient while signing out reports, gives a clear and comprehensible report, and obediently does all procedures as per clinician's requests with no questions asked. On the other hand, an ideal clinician in the eyes of a pathologist is one who does not fuss with the report, even if it is grossly erroneous or reported way beyond the turnaround time, gives a detailed history of the patient sent for the evaluation, understands each and every jargon he uses in his surgical pathology report, and discusses with the pathologist before requesting any procedure. The irony is, nothing is ideal in this world. Now, when we talk about turnaround time, it is defined as the time calculated from the time of receipt of the sample in the laboratory till the time of certification or authorization of reports. And we know that different tests in the laboratory have different turnaround times. However, sometimes there is a potential conflict between the turnaround time versus the report quality. Now, this is an example of a tumor specimen which we had received in our laboratory. And what was the dilemma? The dilemma was whether it is a fibrosarcoma or whether it is a mitotically active cellular fibroma. Now, a fibrosarcoma, as we all know, it's a cellular neoplasm with definite nuclear atypia, where there is a breach of capsule and a high mitotic count. On the other hand, a mitotically active cellular fibroma has cellular neoplasm with no atypia, no breach of capsule, and high mitotic count may be as high as that of fibrosarcoma. So in this case, unless we give multiple sections from the sample, from the tissue sample, it is very difficult to give out a report. So so that was the dilemma in this case. And in such cases, the turnaround time may not be, as per the protocol. So in these cases, we always have to communicate with the clinician and let them know that in such cases, the turnaround time may be high. Coming to history and background of the patient. Now, there seems to be a perception amongst many that history of a patient, if provided with the test, may cause bias in reporting. Now, although most of you will definitely agree that a final diagnosis is often more accurate and sometimes can only be made in the light of other clinical information. Withholding information from a pathologist not only demeans and ignores his expertise, but also increases the likelihood of errors. Now, you see, these kind of, worksheets that are received in the laboratory, that this is a worksheet with no clinical history at all. The history, the part of the history, the place where we should write history is totally blank. Now, this is a history which we received. The history is written stool in blood, which does not mean anything. Now, this is a history which we received, which shows gay no problem. I don't know what it means. Now, this clause from NABL ISO 15189, it clearly mentions that, we should have clinically relevant information about the patient and the request for examination performance and result interpretation purposes. So this clause says that we should have clinically relevant information from the patient. The pathologist should have clinically relevant information for diagnosis. It is not that we are emphasizing on this. It is the clause from NABL. So talking about comprehensibility of reports, just as medical language may be hard for lay people to understand, it may be also hard for the clinicians to understand. So it has to be, it has to be interpreted in a way that they understand properly. Otherwise, just writing funny looking cells in pink and violet correlate clinically would not be helpful for the clinicians. So to do away with such problems, standardized reporting formats like Bethesda system, CAP protocols, etc., need to be adopted. And this emphasizes the use of synoptic reporting. Now, what is synoptic reporting? It is a process for reporting specific data elements in a specific format in surgical pathology reports. Previously, surgical pathology reports were highly narrative, prone to omission of necessary data and inconsistencies in formatting. Now, in practice, the College of American Pathologists has been promoting synoptic reporting for more than 20 years. And for practicing pathologists, synoptic reporting refers to specific elements in cancer protocols and a specific format required by lab that ensures completeness of reported data elements. Now, this is an example of a report which shows example of a TURP specimen report. Now, this is a very narrative report which is shown as an example. Now, on the other hand, if we use a synoptic reporting, now we can give a report like this, which is, at par with a synoptic reporting format. Now, see, this is a very clear report which gives a clinician the whole idea of what has been there in the specimen that has been sent for histopathology. Now, communication is the key to all problems. Consultation and collaboration are the key to planning therapy. Only by communicating and balancing their needs, clinicians and pathologists can accomplish their missions. What are the barriers to communication? Potential barriers are, logistical issues and at times the patient themselves. Increasing mobility of patients, both geographically and among local healthcare systems may help. Now, this is a very interesting, sentence which has been adapted from this book. A mystic perversion of this assumption prevails amongst those clinicians who believe that pathologist, given only a piece of a patient's tissue, has all of the other ingredients necessary to produce a statement of absolute truth at the end of his report. Now, more dangerous to mankind is a pathologist with the same concept. Solutions for better relationship are hospital laboratory review boards, clinico-pathological meetings, integrated teaching sessions, participation of pathologists during clinical rounds, training goals for clinical residents in pathology, and laboratory information system, hospital information system, and electronic health records. How do we ensure quality of reports? By internal quality assurance in the laboratory, external quality assurance schemes, and monitoring of machine-generated reports by faculty. Always, if there are errors, we have to find out the root cause of those errors and perform corrective and preventive actions. There are accreditation bodies like NABL, CAP, and JCI for ensuring quality of reports. Now, then coming to the last part, do pathologists need to communicate with patients? Of course, we need to communicate with the patients. Gone are the days when pathologists used to sit behind closed doors with their eyes glued to their microscopes. Nowadays, we are expected to communicate not only with the clinicians, but also with the patients. And although it may be an eyebrow raiser for many who think that it is only for the clinicians to interact, most of the time, test requisitions are not accompanied with proper clinical and therapeutic history. Now, it is at that time when we have to come forward and have a word with the patient ourselves. Because you see, Terry Canal, in his vice presidential address at American Academy of Orthopedic Surgeons, he rightly mentioned that the patient will never care how much you know until they know how much you care. And His Holiness Dalai Lama, he rightly mentioned, when you talk, you are only repeating what you know, but if you listen, you may learn something new. So we have to practice the art of listening. Only then we will be able to provide proper care to our patients. Now, patients often keep wondering and worrying about their report interpretation until they get an appointment with the treating clinician. So we can then come forward and talk to the patients while dispatching the reports and try to explain the finding to them ourselves. So there are concepts of pathology explanation clinics in the Western world where the reports are explained to the patients by the pathologists themselves. So these kind of explanation clinics can be, established in our country also. So besides our clinical skills, there are 5 things that protect us from medical legal problems. These are communication, documentation, communication of documentation, documentation of communication, and preservation of documentation. So in summary, the synergism of collegial and cooperative relationship between clinicians and pathologists is indisputable. Effective communication, trust, and relationship on each other's expertise are needed. Together, we can achieve more than we can apart. And this is an era of patient-centered care, and we as pathologists should try our best to expand our roles. We bear the responsibility for our patients, and failure to do so may have diagnostic, therapeutic, and legal consequences. So we started that with the thought that pathologists are from Venus and clinicians are from Mars. But this is a recent article which says that pathologists are from Mercury and clinicians are from Uranus. So, I mean, from whichever planets we may be from, but ultimately we have to work as a team, and we have to work for our ultimate beneficiaries, and our ultimate beneficiaries are our patients. So with that, I end my presentation. Thank you for lending your ears. Thank you. So with this, I think we have come to the end of our session for today. The session was on recent trends in pathology, from teaching methods to diagnostic tools. And I thank all our speakers, Professor Dr. Anup Kumar Bolet, sir, Professor Dr. Sonia Madam, Professor Dr. Priyanka Gogoi Madam, Professor Dr. Yokarin Khongla Madam. Thank you for sparing your time and joining the session for Asia Pacific Advanced Network Medical Working Group, and giving your extensive insights on your expertise on your domain. And I hope that in future too, we will have such sessions with Asia Pacific Advancement Network, and we will have such platforms for sharing our views. I once again thank APAN for giving us this opportunity to have this session on pathology. Thank you so much. I think we can end this session here.
Thank you.
Thank you. Thank you. Thank you.
Thank you, Dr. Ashifa.
Thank you so much. Thank you.